right, so I'm here to talk about navigating the autism diagnosis process. Come on in.
I'm coming.
You're good. Just going to talk a little bit about insights and approaches. To tell you a little bit about who I am, my name is Dr. Andrew Jones. I have a PhD in counseling psychology from the University of Iowa. I'm the clinical director of psychology at ABS Kids, and so in my role there, I oversee a team of about 20 psychologists across the country, across Utah, North Carolina, South Carolina, and Tennessee. And so I'm licensed in all those states. I see patients in all those states, and I oversee a team that performs about 4,000 evaluations for children suspected of having autism per year. So that's really what my specialty area is. I train people to do autism assessments. I have postdocs that work under me. I'm really dedicated to early identification of autism so that children can get access to services that they need, and also in training individuals and more psychologists, because really when I think about autism diagnostics, it's a niche within a niche. So most psychologists don't go into diagnostics and performing evaluations, and the majority of those psychologists don't want to work with individuals under 6 and don't focus on autism. So that's really why I think of it as like, this is a huge need for our community when we're seeing 1 in 36 kids who are being diagnosed with autism, because we don't have the providers being trained adequately to perform those services so we can identify them and get them into the treatment that they need. I also own and operate my own private practice. It's called Carolina Psychological Institute. In that private practice, I perform evaluations for individuals across the lifespan. I don't just focus on autism. I've seen 2-year-olds and I've seen 55-year-olds. And so in that, I see patients on the weekends, so it doesn't interfere with work and school. It's just kind of an added thing I do in the community where I think it's a valuable service that individuals need. So, talking about the diagnostic process, the diagnosis really, the process starts from a very young age, and it's usually, moms. Moms always know is what I say, and moms are with their child and they see, okay, maybe something's a little different. Yeah, maybe there's something I wasn't expecting. So, in terms of early development, moms start picking up on that at around 12 to 18 months sometimes, right? Especially when the symptoms are a little bit more apparent. So there's different things that we look at developmentally based on a child's age. So some of the early warning signs of about 12 to 8 months, there's this limited response to others. Maybe they're not smiling in response to you. Maybe they're not responding to their name. Developmentally, we expect a child to start responding to their name at about 6 months, 12 months on the later side. So when you're getting up to 18 months and there's still that lack of response to name, I always tell parents, okay, let's start with an ENT. We always want to rule out a medical diagnosis first, see if there's something going on with their hearing. If not, maybe we should look and potentially pursue an evaluation for autism. From 18 to 24 months, we often see speech delays. A speech delay is not autism. They are two different things, but sometimes individuals with autism have speech delays, and that can help us, okay, maybe we need to look at their whole developmental profile since we're seeing some delays with speech. You'll see differences in play, so maybe a lack of interest in playing with others. They're not engaging in pretend play with others, and then you're also looking at some nonverbal communication, not just speech. Are they pointing with communicative intent and using gestures? We always talk about 16 gestures by 16 months. When we're getting to 18 to 24 months and we're seeing that lack of communication through gesture use, that's a potential red or pink flag for autism. From 24 to 36 months, this is where I think we see typically some of those more hallmark symptoms of autism, because developmentally I have different expectations for a child. Lots of kids toe walk when they first start walking. It feels good for them to walk on their toes, and they're just exploring. And I expect that exploration to happen, but when it happens consistently and it continues to go past 24 months and it's really pervasive, that's when I see it as maybe a red flag associated with autism. And that's when you'll see difficulties with transitions, maybe some sensory aversions to food, some more of those hallmark symptoms that I'll talk a little bit about later on, because one of my big issues with the diagnostic process is I think a lot of doctors don't explain to families, this is what autism is. Sometimes they just say, yes, your child has autism, but they don't give you the tools and understanding to really wrap your mind about what autism is and where do I go from here. So, you see some of these early signs, and then to me the first question is, who can perform an evaluation? Because that's really where you need to start on that diagnostic journey. So your best bet generally is to have a licensed psychologist or a developmental and behavioral pediatrician perform the evaluation. All insurance companies are going to approve of these providers, so their credentials are generally PhD, PsyD, or MD. That is your safest bet. There are other providers in the community that can do the evaluations. It's just, there are some complications that arise. So, there's something called a licensed psychological associate in North Carolina. They are master's level clinicians who are trained to do autism assessments. They can do them ethically, but the insurance companies will say, we don't approve of these credentials. So when you go for ABA authorization or whatever services you need, they're gonna say this diagnosis isn't valid based on the credentials, which is mind-boggling. So I have LPAs that work for me and I have to sign off on every report they do just to make sure that their child, the child that they saw, doesn't have any delays in services. There's also school psychologists. School psychologists are fantastic, and they are very well-trained professionals who understand autism. And in North Carolina, school psychologists cannot diagnose. So a lot of times families will say, yes, I'm on a wait list, I'm gonna get evaluated through my school, but you can't get a formal diagnosis. In South Carolina, you can get a formal diagnosis, but if they're a school psychologist, the state doesn't accept those credentials. So then they get denied for therapies. So there's all these little nuances, right? And I've learned about these nuances because I work in both North and South Carolina, and they're frustrating to me as a clinician because there's no playbook for families to say, okay, this is exactly what you need, this is the roadmap you need to follow. And even me as a doctor who's an expert in this area, I feel like I'm always learning new things because I could go on a lot of rants about insurance companies, but they're always changing things up, and it's hard to follow what they want you to do so that families can get the services they need, even though they're supposed to be serving families. Okay? So I've also seen in the community false promises from providers, and that's something that just like morally and ethically like makes me mad to my core. I've seen a lot of families and providers will come up to them and say, hey, you know, I'm just gonna do the ADOS for you. Pay me cash, take it back to your doctor, and they'll sign off on it. I've called a couple practices and I said, stop doing that right now, because you need an entire evaluation. If you just have an ADOS and then you tell somebody, have your doctor sign off on it, the doctor's gonna look at you like you're crazy and they're gonna say, I don't know this person. I don't know what they did or why they did it, and I'm sure as heck not signing off on it. And then I have families who later find me and they're like, now my treatment was delayed a year because I thought that this was gonna, you know, get my foot in the door. So now that we know who can perform the evaluation, then you need to actually find your doctor. So to me, it's easy to find a doctor. It's hard to find a doctor who takes your insurance, has a short wait list, and is going to meet all the standards of insurance to ensure that there's no roadblocks for your future. So as a parent, like Dr. Magger was saying, you're the biggest advocates for your children and for the individuals going through this process. I would say these are the things that you should be asking the doctors just to make sure, right? What's your wait list? What insurances do you accept? Do you follow all the guidelines to ensure that there will be no roadblocks in the future for my child? That's what I would do as a parent. So a good place to start in finding a doctor is to go through your insurance. Most insurance companies, they have websites where you can look up providers who are in your area. And then I would say do due diligence, because oftentimes those lists are wrong. So use that list as a potential guide and then follow up on that and do a little legwork and call them and ask them some questions. PsychologyToday.com is a great way to just find resources of psychologists and therapists in your area. You can filter by geography, you can filter by what you're looking for. That's a resource that I recommend for people looking for evaluations and for therapy. And then there's also the Mecklenburg Psychological Association. I really love this group. I'm a part of it here in Charlotte, and it's a group of psychologists and therapists who are licensed in North Carolina. And they're all working together to try to find services for their patients. There's emails every week, and it might be, hey, I've got an 8-year-old, they have Aetna, and they need an evaluation for ADHD. And it's sent out to all the psychologists in the area, and somebody will say, hey, my practice specializes in that. We want to help you out. So I love that. That's something that I think is pretty unique to Charlotte, is that we have a big group of doctors who want to work together to put the patients first. Also, just word of mouth tends to be big. Psychologists are terrible business people, right? We don't talk about business in school. We never talk about marketing yourself. You know, they're not good advertisers. So typically you find out about people through word of mouth, and it might be somebody that your pediatrician knows or is friends with. So Talking with your pediatrician is always a good way to try to find people. My wife's a member of different Facebook groups. And it's, Facebook groups for moms with children who are neurodiverse and et cetera. And sometimes she'll be like, hey, this mom's asking for this. What would you tell her? And I love that sense of community in these groups and how it's just people trying to help people and trying to get you resources, okay, either through your insurance or through grants or whatever, to get your needs met. When you're in the process of finding a doctor, be selfish, get on multiple wait lists, right? Do what's right for you, do what's right for your child, whatever you need to do. Just cancel the other appointments when you get seen. It never really bothers me because we see a lot of patients and sometimes they're like, hey, you're supposed to show up for your appointment today. And they're like, oh, I was seen a month ago. I'm like, you know what? That's fine. I'm just glad that you were seen. But get on multiple wait lists. Then it comes to payment for the evaluation. This is where things can get a little bit tricky. There's a lot of different ways to pay for an evaluation. There's private pay or self-pay. So I'm just talking straight out of pocket. The estimated cost for an autism evaluation is about $1,000 to $3,000. That depends on the child's age, it depends on the complexity of their needs, depends on the market that you're in, right? Most psychologists in Charlotte are private pay. There's a whole number of reasons for that, but the wait lists for insurance tend to be long. So that's why you need to shop around and get on multiple wait lists, and I would encourage anybody to do that. When you're paying through your insurance, the costs are payer specific, and you should consult with your insurance about that. And most doctors that you're seeing can give you an estimate of how much it'll be ahead of time, but generally you're paying very little unless you have a high deductible health plan. So I always tell people, try to use your insurance first, because these evaluations are very costly. Schools, like I mentioned, schools can provide the evaluations. They're free, but I've talked about where there are some downfalls there. And that can be that, the providers in the schools are focusing on school requirements and what they need to do for either their IEPs or other documents. They're not focused on insurance, and oftentimes they can't give the formal diagnosis that'll be recognized by insurance. Lastly, there's grants. These are great, they're free. So one of the things I want to highlight is the Autism Strong Foundation's emergency grant funding. So as part of their emergency grant fund, they set aside monies for individuals looking for psychological evaluations. That's actually something that I've partnered with ASF on, so I actually perform the evaluations. And that's been something that's been really meaningful to me, where these individuals who have been on the diagnosis journey for years reach out to ASF, and then they complete their application, and I've seen them within a week. So now, they thought maybe it was going to be another 6 months to a year before their child could get services, but in a week they're able to get them. So that's something I've been really proud to partner with ASF on, and it's something I love to brag about because it means so much to me that they do that. So when you're actually being a part of the evaluation, there's different tests that are involved. So the MCHAT is maybe something that you've heard about. This is a screener that pediatricians use, and it's used by pediatricians at generally the 18-month well check. And it's where your doctor's gonna ask you some questions about your child and are they exhibiting symptoms that are more or less associated with autism? This is where the vast majority of autism-specific referrals come from for psychological testing. It's from the pediatrician, and if there's flags on that MCHAT, they'll send it over to me or other providers in the community. The tests that are actually used in the diagnostic process would be the ones under the MCHAT. You've probably heard of the ADOS. That's the Autism Diagnostic Observation Schedule. This is considered the gold standard tool for autism diagnostics. I did not deem it the gold standard. I think that's what the industry deemed it. I like the ADOS. It's a good tool. It's entirely dependent, though, on the clinician. The ADOS is a way to gather behavioral observations of a child. So you're engaging in play with them. You're engaging in pretend play, imaginative play. You're blowing bubbles. You're doing routines, maybe tickling and other things. So to me, there's nothing super proprietary about the ADOS. I'm just playing with the kid, right? The important pieces of the ADOS are how you're scoring up those interactions with the child. Are they making eye contact? Are they using gestures? Are they pointing? Are they doing more complex gestures? Those are all the little things that you look for in an evaluation. So an autism evaluation, to me, the number one tool is your clinician. If your clinician understands autism, knows what to look for, and knows how to elicit behaviors that may or may not be associated with autism, That is the bread and butter. That is the gold standard assessment tool. Clinicians who don't know what to look for those things, don't know the autism language, don't understand those behaviors, it's not going to be a good evaluation no matter what tool they use. So when you're looking for doctors, ask them what they think about these tools. Ask them how they do the assessments, how they think about autism. You are consumers of this evaluation. You should shop around. You should be picky and choosy, right? Sometimes it's hard depending on wait lists and other things, but we want what's best for the child, for the patient. And so, I say the same thing to people who are in therapy. You're not tied to your therapist, right? You can break up with them. You're not tied to them for life. You need to do what's best for you. Don't worry about their feelings. If you call up a doctor and you learn about them and you think, okay, this might not be a good fit for me, move on. Another commonly used autism assessment tool is called the CARS. It's the Child Autism Rating Scales. This is a little bit different from the ADOS. This is a clinician-scored rating scale, and it's based on my observations of the patient, parent report, and what I learned about the child on rating scales and records. I like this. It streamlines your evaluation a little bit. Individuals who are level 3 nonverbal, sitting and doing an ADOS and forcing them to be there with you for an hour as you poke and prod feels terrible to me as a person. I don't want to do that with every patient. I would much rather, if I'm able to get the behavioral observations I need and learn from the experts, the moms, the dads, I'm good. I'll stop poking and prodding once I've seen enough, as opposed to feeling like I have to go through this regimented procedure that's not appropriate for every patient that walks through my door. The ASRS and SRS, so the Autism Spectrum Rating Scales and the Social Responsiveness Scale, these are rating scales that I often send out to parents ahead of time before the evaluation. I don't use them diagnostically. How I use them is I like to get a barometer, a temperature of how the parent is feeling coming into the evaluation. I like to know where their head's at in terms of where they're rating symptoms and compare that with questions I've asked during the triage and intake process. If I know where the parent's at, that's to me one of the most important things in an evaluation. I want to know where the parent's at so that I can walk beside them, hold their hand, and guide them through this process so they can hear what I'm saying and I'm not just dumping something on them that they're not emotionally ready for. So sometimes I'll give them some rating scales ahead of time and everything is completely average, no concern in the world. That could mean, yes, your child does not have autism. It could also mean the parent's in denial. And it could mean they really need some psychoeducation and they really need me to lean in from an empathetic perspective to be able to connect with them before I start telling them, okay, this is what you need to do for your child. This is what your child has. And that to me is one of them, connecting with the parents and teaching my doctors to do that and think about them as people and how we do this journey of diagnosis. That's the most important thing to me. We also use rating scales like the DP4 and the Vineland-3. These are adaptive functioning rating scales. Adaptive functioning skills are often impaired or below expectations in individuals diagnosed with autism. And that doesn't necessarily mean across the board. So a lot of the times I'm looking at daily living skills, socialization, communication, physical skills, motor skills. Some of those skills are going to be average, high above average, well above expectations for their age. But oftentimes you're going to see some social emotional deficits, and these rating scales will give a little bit of insight into that because you're wanting a nice holistic picture of the individual from the parent's perspective, and then I'll also interact with the child and get my own observations. So there's also evaluation requirements. I talked about some of the tests, but these are some generalities about evaluation requirements. They're different in North and South Carolina. In North Carolina, you can use the CARS or the ADOS as your autism-specific tool. So that's why I said if I get a patient in, they have significant behaviors, I don't need to do a full ADOS. Maybe I just do a couple tasks from it. I do a clinical interview. I do an adaptive functioning questionnaire. It has to be signed by a licensed psychologist or MD. They do not require pre-authorization, so this is kind of getting into the weeds, but this is something I really like about North Carolina. Access to services in terms of diagnostic evaluations is far better in North Carolina than South Carolina. In North Carolina, I could do telehealth evaluations. I will caveat, telehealth is not appropriate for every patient. For patients, I like to do telehealth on patients 4 and under who have a significant number of symptoms. Individuals who are 5 and up or have low levels of symptoms, I think are more appropriate for in-office visits because their symptomology tends to be more nuanced. And so really allowing for me to interact with them and see them right in front of me for a couple hours is more important to me in those cases. Pre-authorization means your insurance company has to decide whether or not the evaluation is medically necessary. I can't think of any reason why any 2, 3, 4, 5, 6-year-old with developmental delays, it would not be medically necessary for them to be seen by a doctor who wants to investigate their development. So North Carolina, I really like their standards. And these are based on Medicaid standards. In South Carolina, it's far different. You have to use the ADOS with every single patient, right? You as the doctor have no say. It's just patient ADOS, no matter what. I also include an adaptive functioning questionnaire. It needs to be signed by a licensed psychologist or MD. They require pre-authorization. So what that means is you do your initial clinical interview, and then the insurance gets to give you a thumbs up or thumbs down on whether or not they think your child is worthy and medically necessary of being diagnosed. I had a patient a couple weeks ago, history of complex trauma, ADHD-like symptoms, potential concerns for autism, almost 4 years old. Insurance said, no, not worth it. You did a clinical interview with them. We're not going to pay for testing. So I said, okay, we'll eat it. But I'm still doing the testing because I want to give this parent and family the best recommendations that I can. They didn't have autism. That's okay. But they had severe trauma and ADHD. Typically, I won't diagnose under age 4, but this patient their symptoms warranted an ADHD diagnosis. You cannot do telehealth appointments in South Carolina, so that also presents barriers in terms of access to service. And so taking all those things, I primarily operate in North Carolina, and if I would not work in South Carolina full-time. And there's access to service issues because of that, and I'm trying to advocate at the state level in terms of like legislature, so they don't like me very much. So how I do them, any psychologists you talk to, they might say, I have a standard battery. I hate that language. Every child is unique and different. Your battery should be bare bones if you have like a core test that you always use, because then you build off of it based on where the evaluation goes. So for me, a core bare bones battery is what insurance requires. That's what insurance requires. So that's my bare bones battery. I'm not going to add 5 more tests in there just because I want to keep you longer and bill for more. I think that that's unethical. I should do what I think I need to do to meet insurance requirements, and if I need more information, I'll go from there. So in North Carolina, that's my bare bones battery. CARS, Autism Spectrum Rating Scales, Developmental Profile 4, checks all of our marks off that we need. I can do it telehealth or in person. I've told you how I think about that. For individuals who are 6 and older, I like to perform cognitive testing. I think at this time, you can't diagnose an intellectual disability until age 5. Individuals under age 5 with significant delays, they'll get diagnosed with global developmental delay, but that diagnosis disappears when they turn 5. At about age 6, when individuals have severe cognitive delays, I do feel like that's a time that it's okay to start diagnosing an intellectual disability. And so I'd want to get those cognitive scores. But I think it's a good rule of thumb to start doing cognitive testing around that time so that you have a baseline understanding of their cognitive functioning and you can work off that. You know, people talk about IQ, it gets pretty set in stone once you're like 9, 10, 11. So around 6, we can still see some changes in development. So I tend to be a little bit hesitant about an intellectual disability diagnosis unless the symptoms are very profound. And in North Carolina, I can do my assessments all in one day because I don't have to worry about pre-auth. In South Carolina, swap out the CARS for the ADOS. I can only do the clinical interview via telehealth, then I have to wait a week or 2 for authorization. So multiple appointments create multiple points of barriers for families. But then I also will do cognitive testing once they turn 6 there as well. One of the things I mentioned earlier is that I don't think doctors always do a good job of talking about autism and what it is. They might just say, your child has autism. But help me understand that. There's a bunch of definitions on TikTok of autism. There's a bunch of people, lay people, who only understand autism as whether or not you make eye contact. With every patient I see and diagnose, I reference the DSM criteria and I say, okay, autism is a two-pronged diagnosis. It's a really long word too. The full name is autism spectrum disorder. It's a two-pronged diagnosis with social symptoms and behavioral symptoms. On the social side, there are 3 symptoms, and you have to meet all 3 symptoms either currently or by history. The first is deficits in social emotional reciprocity. So think about difficulties with like back and forth, give and take in social interactions. Okay? Maybe they don't respond to their name regularly. They struggle with conversations, they're one-sided. The second is deficits in nonverbal communicative behaviors used for social interactions, eye contact, lack of gesture use, understanding gesture use, integrating gesture use. Maybe their facial expressions don't match their emotions, so their mood and affect are often incongruent. Sometimes you see children and they're often grimacing, or they're making facial expressions that just don't match their mood. They're smiling when they're upset. And then deficits in developing, maintaining, and understanding relationships. So a child who maybe only engages in solitary or parallel play as opposed to joint interactive play. Or maybe they struggle to engage in pretend play, make friends, or they're just not interested in others, right? And sometimes, that's okay. We're all different social beings. We don't all have to sit there and talk and have small talk all the time. All of our brains work beautifully and are designed in different ways. And there's nothing wrong with not wanting to sit there and do the small talk or wanting to play on your own. It's just a social difference, okay? Then we have the behavioral symptoms. So there are 4 symptoms on the behavioral side. You have to meet 2 out of the 4, either currently or by history. The first, I just think of, has to do with repetition. Repetition in speech, play, or motor movements. With motor movements, I ask every family, does your child, currently or historically, engage in any of the following repetitive motor movements? Hand flapping, toe walking, rocking, running. So with running, I say this to parents and they always laugh. I'm like, don't take this the wrong way. But does your child ever seem like they have the zoomies, right? Kind of like a dog when they get out of the bath. So hand flapping, toe walking, rocking, running, pacing, spinning, jumping, excessive and forceful blinking is one I see from time to time. And then hand and finger stereotyped movement and posturing. So the way I think of these is I think of them as involuntary. It's not like the child is sitting there and thinking, you know what, I'm gonna hand flap right now. No, there's just signals getting sent from their brain at different times, and sometimes it's emotion-based, and you see some of those behaviors, okay? There's also repetitive play, so that can be lining, sorting, stacking in a repetitive manner, or repetitive speech. The most common form of repetitive speech is echolalia, so echoed speech. So sometimes you see kids who engage in immediate echolalia, where they're parroting what you've said directly back to you, or they engage in delayed echolalia. Maybe they have a favorite cartoon character, right? One day I was like doing cognitive testing with a kid, and he would just he'd give me an answer, and then he'd just be like, it's me, Mario, and then just get right back to what we were doing. So some of that delayed echolalia, just working in some of his favorite phrases. I have an axe to grind with YouTubers. A lot of these kids are now echoing YouTubers, and it's weird stuff that YouTubers say. So you kind of have to be chronically online as a doctor to know the skibbity riz or random things that kids are YouTubers are saying and what the fads are, because you might hear some of that stuff or TikTok trends that kids are saying and engaging in, and you wouldn't know that it's echoed speech unless you're chronically online. So the second symptom has to do with insistence on sameness and flexible adherence to routines. These are children that really struggle with transitions. Oftentimes in early development, this is the symptom that, in my opinion, impacts families the most. You've got the parents who are I can't go to the grocery store. I can't go out to eat anymore. And it's also you take a different route in the car. And that child starts engaging in persistent questions about where they're going, or maybe they have to eat the same food for the same meal every single day, or it's I have to eat off a certain plate, I have to have a special cup, right? So just insistence on particular routines above and beyond what you'd expect. All kids like routine, right? I'm not pathologizing, okay, I want my bedtime story. No, that's normal. Right? But so it's kind of the frequency, severity, and duration of things is when they become pathological. Third, we have highly restricted fixated interests that are abnormal in intensity or focus. Dr. Magro was talking about his earlier. This is my favorite symptom. Some people will talk about autism as a superpower, and this is what I think about with the superpower. I've had 4-year-olds who can tell me all the planets and their moons and what they're gaseous or facts about them. I had a 9-year-old in my office one time, and he's just staring at the window, and I was like, "What are you thinking about, buddy?" He said, "D-Day." He proceeded to tell me about D-Day for 20 minutes. His perseverative interest was World War II. So it's just these intense interests that go above and beyond what you'd expect that are just beautiful and awesome, and I love it. As a doctor, sometimes I just want to nerd out with the kids and be like, just tell me about your interests. Let's just talk about it more. But then I have to remember, I need to get back to the evaluation. And sometimes it can be with young children who are nonverbal. It's I've had kids, they carry receipt paper with them wherever they go, or they only want to play with sticks. It's just kind of these intense focus and interest. And when they can't verbalize it, it's a little bit harder to identify. And it might just be I watch Cocomelon over and over and over and over and over. Lastly, we have hyper or hyporeactivity to sensory input. So to put in layman's terms, I think of sensory seeking behaviors and sensory aversions. Sensory seeking behaviors, persistently putting objects in your mouth. Developmentally, I don't expect that about past age 2, 2.5, the consistency of it. Fascination with lights, spinning objects, movement. Persistently smelling objects or people, persistently touching or rubbing mom and her earlobe or her arm. Those are the sensory seekers. Then we also have people who can be sensory avoidant, and you can be either, right? You can be a sensory seeker and a sensory avoider, or you can be one or the other. For sensory avoidant, covering your ears, crying, getting upset when you hear loud noises. Public restrooms are a huge enemy to young children with autism. They've got loud toilets. We've got the hand dryers. For our sensory avoidant kids, in my office, I have a light where the fan automatically comes on, and I can hear a shriek sometimes where I'm like, okay, I know that they're a sensory avoider, and I'll warn mom before they go in. And that could be aversions to your hands or clothes, getting wet or dirty, aversions to haircuts, difficulty with bath time, not wanting your head and face touched, or just not wanting people to touch you in general, right? What I just did right there, talking about all those symptoms, I do that with every single family. But I relate those symptoms back to their child. And I think that that's important for every parent to be able to wrap around, because autism is so unique to each individual. So you need to understand the symptoms, I think, at large, but then, okay, how do I relate this back to my child so that I can make sense of it? Because the parents need to make sense of it in order for them to move forward too. Levels. Before I get to the levels to me are one of the most controversial things about autism. The levels changed within the last 10 years. There was no level system. When I get to the diagnosis portion of my evaluation, I talk about autism, how the symptoms relate to their child and how they meet the criteria, and then I say, okay, I want to pause for a second. I'm going to talk about the levels, and I'm going to warn you it's a trap. Do not hyperfixate on the levels. The levels are not indicative of prognosis or future functioning. They are based on very, very little research. They are entirely subjective, so every psychologist who assigns a level, it's going to be entirely different. Think of the levels as an indication of how much support your child needs on this day at this time. Levels are likely to change over time in a positive direction with growth, maturation, and natural brain development. So that's why I say it's a trap. Don't fall into that trap. And I'm going to show you why it's a trap. The levels are a paragraph. This is taken directly from the manual that doctors use to diagnose. So when it comes to levels, you can have levels for social and behavioral. And you can assign the same level or different levels. Most doctors don't do that. So that's a problem to me, because there can be significant differences in levels. When it comes to level 1, it's called requiring support. Level 2 is requiring substantial support, and level 3 is requiring very substantial support. So just think about levels of support. Somebody who's 2 requires more support than somebody who's 50. Somebody who's nonverbal requires more support than somebody who is verbal. And remember, we only have 3 highly subjective options. And as you can see, level 1, without supports in place, deficits in social communication cause noticeable impairments, difficulty initiating social interactions, and clear examples of atypical or unsuccessful responses to social overtures of others, may appear to have decreased interest in social interactions. For example, a person who's able to speak in full sentences and engages in communication, but whose to and fro conversation with others fails, and whose attempt to make friends are odd and typically unsuccessful. This is not a 2-year-old, okay? A 2-year-old who's level 1 is never going to be in my office because their symptoms would be too nuanced for me to determine. Nobody would say, hey, I think this child might have autism. Most individuals, unless they have a co-occurring intellectual disability, will eventually graduate to level 1 based on how the systems are written, okay? If you have a co-occurring intellectual disability, your symptoms tend to be more severe and your overall development delayed. But I'd say most individuals, by the time they're 7, 8, 9, 10, 11, would typically fall under the level 1 category. So that was level 1 social. Level 1 behavior is inflexibility of behavior causes significant interference with functioning in one or more contexts, difficulty switching between activities, problem of organization, and planning hamper independence. So I can read those sentences. They don't mean a whole heck of a lot. They don't touch on the vast nuances of autism, and they're not backed by research. So that's why me as a clinician, I take issue with the levels, because families just, one of the first questions they'll ask me is like, is it level 3? How severe is it? And I'm like, I need to answer those questions in a very nuanced way because these levels are not nuanced, and we need to think about it from a bigger perspective. Level 2, marked deficits in verbal and nonverbal social communication skills, social impairments impair even with supports in place, limited initiation of social interactions, and reduced or abnormal responses to social overtures from others. For example, a person who speaks simple sentences whose interaction is limited to narrow special interests, who has markedly odd nonverbal communication. Okay, so this is typically going to be your younger kids, right? Maybe getting up to that 7, 8, 9 where they're starting to develop a little bit more, but their language is still a little bit delayed and they really hyper-focus on some of their interests. Behaviorally, inflexibility of behavior, difficulty coping with change, or other restricted repetitive behaviors appear frequently enough to be obvious to the casual observer and interfere with functioning in a variety of contexts. So you'll see when I switch from level 2 to level 3, like they're almost exactly the same. They just change like marked deficits, severe deficits. Difficulty coping with change, extreme difficulty coping with change. So we've just taken subjective definitions of levels and then added more adjectives that are on them in a subjective manner. So again, when I think of a level 3, I think of an individual who's likely nonverbal and has the really hallmark hand flapping behaviors, difficulty with transitions, things that are really apparent to the untrained eye. When I think of level 2, I think it's a little bit more nuanced. They probably have some speech skills, but maybe their behaviors really impede them from developing any sort of friendship or navigating different environments. Level 1, most of these people are going to be pretty successful, right? Parents will ask me, I'll say, the sky's the limit, right? They can go to college, they can get married, all the things that you want for your child, they can probably do. We just don't know if they want it yet. I also like to talk about the 5 stages of grief. Dr. Magro earlier talked about, telling parents and talking with parents. And whenever I have a parent in my office, I do tell them your child's the same child they were an hour ago. So that really resonated with me because that is something I train all my doctors on. It's still the same child. They still need that same love, care, and attention that you gave them right before they came in. Now, that doesn't mean it's easy on a parent to hear those words and to hear that diagnosis. So I like to affirm parents and say, you know what, you should be really proud of yourself for bringing your child in here. You should give yourself a pat on the back. And if you're in a relationship, don't lose your love for your partner or your care for your partner in the diagnosis. The diagnosis is there, we'll get some things in place, but don't lose yourself in it. Have compassion and care for yourself. Now, the 5 stages of grief, how does that play into the diagnosis process? Well, once I say those words, your child is diagnosed with autism, parents often rapidly cycle through the 5 stages of grief. I've seen all 5 in my office in a short span. Denial. This can't be right. I need a second opinion. Okay, you're welcome to do that. But I'm telling you, based on my expertise, I truly think that this is the right diagnosis for your child. And my focus, you can go ahead and get that second opinion, but let's try to get them in therapies while we're waiting for it. That's my approach. I don't want to delay services for a second opinion. Anger. Why my child? Or who are you to diagnose my kid? Where did you go to school? How old are you? Bargaining. Maybe if I do everything perfect, my child will speak in the next 6 months. My child will do this. They just need you to love them and be there and be present with them each and every day. That's it. Depression. This is overwhelming. This is my fault. What did I do that was wrong? I see this from moms all the time. I took Tylenol once during my pregnancy. That's okay. That is one of the saddest things to me, right? And I just urge people, everybody's brains develop differently. There is absolutely nothing you did to cause this. Acceptance. My child is perfectly amazing as they are. Let's move forward with recommendations. Sometimes it takes us a little bit to get here. And you might be cursing me or not hearing what I'm saying in the moment, but we all get there eventually, okay? All right, so that is it. Any questions that you all have? I know that I'm like having to wrap up.
Can you talk a little bit about the adult and what happens, like, I don't know, anything you can share about an adult? Because I have an adult son, actually, when he was diagnosed, autism was really just starting to be heard of a lot, so, yeah, and now we've been told we'd be in requesting some services, I think a functional home assessment, but we haven't had an assessment since like high school, and it was done by a school psychologist, but it got us what we needed, yeah?
Yep, so most insurance companies, if you're trying to apply for services, are gonna say, we want a report in the last 3 years. So that could be what you're running up against, where they're wanting an updated, cognitive, adaptive, and autism just to reaffirm those diagnoses. And so I would pursue the same avenues of, okay, let me try to find somebody in my area with a short wait list who takes my insurance and get on a few wait lists. Okay.
Is there a place where we can, as parents, have access to like all of the terminology that is like spewed at us in school, like IEP meetings and like adaptive functioning, all that stuff? Like I'm learning all of it, but when I go to a teacher or I go to, like his school team and I'm like, oh, I'm seeing this behavior. I don't know what it is. I don't know if it's related to autism, ADHD, Tourette's, and I sit there and I'm like, I'm seeing this. Are you guys seeing it? And is it related to one of those diagnoses? Is it just, it's just him?
This is just a typical development.
Yeah, is it connected to like the executive function? Is it, connected to like
Sure.
anything? And I feel like with schools, like they're super supportive of this, but I feel like I'm sitting there and I'm coming to them and educating them like, that's an executive dysfunction issue. That's this. And I'm still trying to like, I wish I had something to be like, oh, this is what this is. Like, that's how I need to try and go with that.
So if you look online, there's probably like autism dictionaries or executive functioning dictionaries. So those may be things you want to bring to those meetings because a lot of individuals, they're not trained in this. That's not their specialty. And that's not a knock on them. You can't know everything. There's also an educational advocate here today. Her name is Tiffany Yandel. I actually work with her, and she works with families like who are encountering issues at school. She would be a good person to talk to. She should be over at the ABS Kids booth, but she has her own nonprofit. She's also doing a talk about IEPs 504s. I think it's the next section, so you may want to check that out.
Is there, do Do the 5 stages of grief just come throughout like your journey? Like my son is like 3.5 and he'll be 4 very soon. But there's just sometimes in like kind of like at family settings, like at holidays or stuff like that. Like my family members will have like children like the same age, and
Mm-hmm.
it used to bother me a lot because seeing their kids, do their milestones, but just, I guess like grieving, like
Yeah.
that.
Grief is complex, right? So grief is not linear. Where like, hey, I'm going to go through these 5 stages and then I drop off. Even though you've hit acceptance in your heart and you feel it, that doesn't mean those other emotions aren't real, aren't valid, and aren't going to creep their head back up, especially around holidays or other events that can be triggering when you're like, I've had similar events in my family where, it created a rift where I have a cousin who's the same exact age as me, and he was born where the 2 hemispheres of his brain were not connected. We were the first 2 grandchildren on that side, and that created a big rift between my mom and her brother because it just human emotions take the best of us, and that's okay. That's very human to feel those and experience those. And so I would always recommend take care of yourself. If you need to be in therapy, or grief groups or support groups for children with ASD, or even some of those Facebook groups where moms are talking and connecting and doing meetups. Just make sure to take care of yourself and don't lose yourself in the diagnosis is what I encourage to parents. And don't put those stages of grief on time frames or have expectations around them because all those emotions are normal and valid. Okay. Yeah.
Thank you for that. Yeah, because I realized more recently that I was dealing with the grieving stages. My son was diagnosed with autism at about 8. And I feel like it was overlooked before because he was born at 23 weeks. So
I feel anger when I have those cases.
and he was in the NICU for almost a year in the hospital. So everyone kind of looked at it as, oh, it was just, late starter.
Sure.
So it's just, they looked at it more developmental delayed. And then I started noticing some things because I work with Easter Seal, South Carolina. And then I started looking at something is that, kind of like, I think we're dealing with autism. So I had to ask his certain school psychologist to do an evaluation. That's when we started. And then I started realizing that I blame myself. Like, did I not drink enough water? That was a big thing when I was pregnant.
Yeah.
Did I cause him to be born early? And so I still kind of deal with that right now. So that's kind of where I am.
As much as I want to tell you, please don't feel those things. They're normal and you're going to, right? And I just always encourage, just take care of yourself.
You're going to notice in a certain stage, then you go back to forgiving and denying and grief. It just depends that moment that you're in. When you see a child that's your child's age, then, quote, neurotypical, you're like, okay, that would be my son. That's like you. And then you're like, he's perfect, he's my father. So it's just bounces back and forth. And as you say, just take care of yourself. Just remember that your mental health is very important for that child. It's just
Exactly.
normal to just bounce back and forth.
Okay. I'm being told to stop.
I have a question, so we have to go.
No, I mean, I know that y'all have to go, but I mean, there's 10 minutes between now and the next one, so.
So it's not how to word this question, but how do I differentiate between, okay, this is her autistic, but this is also anxiety? Because I didn't know that anxiety was tied
Yep.
with autism. So a lot of time whenever I see this behavior, I'm thinking, okay, well, ABA just fixed this behavior, but then I'm like, no, this is out. Like, so how do I approach that? What services, what do I do with her now? Because we're done with ABA.
Yep.
We're
How old?
past that. Now she's 6, and now we're like high functioning.
Yep.
But
So,
anxiety is like high anxiety.
especially with females. So I talked about the diagnosis and the symptoms. Those are all based on research with males. Same with ADHD.
Yeah.
We're really good at identifying autism and ADHD in a quote unquote male presentation. The female presentation, right? I'm going to call it the quote unquote female presentation. Males and females can have it. It's more nuanced. There's more masking. There's more white knuckling at school, and then you come home and have your meltdown, either with ADHD or autism. Individuals with autism, they tend to be over impacted by anxiety and depression in comparison to their peers. For me, I think just kind of the way their brain works. I think they have like an overactive amygdala, and they're kind of fight or flight, more fear response, and probably more aware of potential threats and things in their environment. So an individual, I would say let's get her started into some therapy, right? Maybe some talk therapy or play therapy at these stages. It could be, sometimes children with autism have trouble identifying their emotions. So, okay, she's verbal, but is she verbal around emotions? And maybe we need to do some education through therapy around education on, what is anxiety? How does it display? What does it feel like? How can I label it? So that's kind of where I would think to be starting is, okay, she's doing great. She's not an ABA anymore. It sounds like there's been a lot of progression. Maybe we need to start with some of those mental health interventions, just to ensure that, she continues to, just be happy and healthy.
Yeah, and that's why I was trying to, okay, so why do I do that? Because for so long, it was always just ABA,
Yep.
ABA.
I would go to psychologytoday.com and try to find a therapist in your area that takes your insurance and specializes in working with young children with autism and or anxiety.
So IEP.
I think it's going to be in here, yeah. We're wrapping up. Yeah. Any other questions, concerns?
So while we're talking about therapy, I have a 6-year-old girl. My son is autistic, he's 10. So I feel like she deals with, I don't know, kind of like the backlash. My son is very verbal.
Mm-hmm.
But he can be really mean to her and she doesn't understand it.
Yeah.
And it really kind of breaks her
Yep.
spirit. So what kind of resources would you recommend for like siblings?
Yeah, individual and or family therapy. There's lots of research on siblings of children with autism, where they also have anxiety and depression, or maybe they feel overlooked because there's so much attention and needs that need to go to the child with autism. So I would say considering either individual and or family therapy, and that would just depend on the family unit's ability to engage in those services as well. Yeah.
I noticed that like ADHD and like anxiety and all that stuff is usually connected with autism, like I kind of knew that a little bit.
Yeah.
How do you go about seeing if you need like secondary testing or like secondary diagnosis? When
Yeah.
just like he's 3.5, so sometimes I can't tell like if it's just like a little
Yeah.
or like
So it depends on the age. So if you're like under 4, there's only a few true diagnoses I feel like you could have. A global developmental delay, autism, and a speech delay are going to be the 3 primary, or maybe no diagnosis, or PTSD. Those are probably like the 5 things I might see. Once you hit about age 4, research shows that you can reliably diagnose ADHD at age 4, but most doctors and clinicians won't diagnose until age 6. Yeah, because when you're diagnosing disorders, you need to look at their developmental age and their chronological age, right? So if somebody's like developmentally 2, I'm not going to diagnose them with ADHD because a lot of those inattentive behaviors I would expect given their developmental age. As somebody gets older, at 6, I'll definitely do cognitive testing, executive functioning, ADHD, and learning disability, because to me, a lot of those, so neurodevelopmental disorders are a class of disorders, and those encompass ADHD, autism, speech, learning delays, and intellectual disability. So I would say especially around age 6, maybe they're diagnosed at age 3, there should be a reeval done about every 3 years anyways. And at that 3-year mark, you might say, hey, or it can come up earlier where you're like, I'm really concerned about ADHD, but at that 3-year mark, I would want cognitive and academic testing.